So good afternoon. First of all, I would like to thank the organizers for this kind invitation. And so the aim of this topic is to discuss about the blood and lab test in rhinology. Usually, our diagnosis can be made based on clinical examination and medical history, but sometimes we need complementary diagnostic tests to have an accurate diagnosis and investigation for a patient. And this is particularly important regarding the United Airway concept, saying that upper respiratory tract disease can influence lower respiratory tract disease. And if it's the case, it can induce morbidity and impact quality of life. Also, some systemic disorders can give symptoms at the level of the paranasal sinus and nasal cavity, and these symptoms may occur quite early in the development of the disease. And early diagnosis is very important to have an effective management and to prevent serious consequences. So today I will overview different kinds of techniques that can be useful in the assessment of patients. First of all, the nasal sampling can be useful to assess the level of inflammation in the nasal mucosa. You can sample the secretions, you can do cytology or biopsy. Nasal secretions are useful to evaluate nasal inflammatory cells and mediators. There are several ways to collect nasal secretions. First of all, you can ask the patient to blow his nose. You can do some nasal lavage. You can use sinus pack or filter papers that are placed in the nasal cavity for 5 minutes, or you can use microsuction techniques. All these techniques have advantage or disadvantage. In research in rhinology, probably the most common technique is sinus pack. If you want to collect some cells, you can do it using cytology. You can either use this cytology brush. This brush is inserted at the level of the middle meatus, is twisted, or you can use this tool to scrap the mucosa of the inferior turbinate, so it's called the rhinoprobe. And when you look at cytology, you can see, for example, here that you have a lot of eosinophilic cells. If you want to see the total mucosa, including deeper layers, then you will have to perform a nasal biopsy. This biopsy can be done under local anesthesia. And in the field of inflammatory disease, it's usually performed at the level of the inferior turbinate. And you see here the epithelium, the deep structure with massive eosinophilic infiltration. Nasal histology is important to characterize nasal inflammation, but it's also very important for the differential diagnosis of several kinds of disease like tumor, rhea, infection, granulomatosis, vasculitis. And as you know, it's also very important when you consider a fungal rhinosinusitis to make the difference between invasive and non-invasive fungal rhinosinusitis. It's also interesting to diagnose eosinophilic chronic rhinosinusitis when quantification of the number of eosinophils is 8 to 20 per field. And meta-analysis found that higher than 55 eosinophils is associated to a higher risk of recurrence. Also, eosinophilic infiltration is associated to prognosis and severity of the disease. Moreover, nasal histology might become important to assist in endotyping and to direct potential therapies such as biologics. And you see here the recommendations from the EPOS 2020 regarding the indication for biological treatment. And you see here that tissue eosinophilia is one of the criteria required to have an indication for biologics. Microbiology can also be a useful tool. You have to keep in mind that you have a normal colonization of the nasal mucosa that is different from the infection. To perform microbiology, you can use nasal swab. It's quite easy and non-invasive. But if you do it, it's better if you do it under endoscopic control at the level of the middle meatus. And you see here that there is a good concordance between endoscopic swab and maxillary sinus content. The question is how representative it is for other sinus. Another way to perform microbiology is to collect nasal brown secretions, mainly in children. It has a high concordance with nasal swabs when nasal secretions are present. You can also use the lavage. Nasal lavage is not accurate, but you can use direct sinus lavage using maxillary sinus catheter. What is the usefulness of microbiology in the management of rhinosinusitis? Actually, there is no evidence of any impact on outcomes. And notably in acute bacterial rhinosinusitis, it's known that around 80% of patients will improve within the 2 weeks without treatment. And moreover, there is no evidence that culture-directed antibiotics give better results than empirical treatment. And following recommendation of the HEPOS 2020, microbial sampling is not recommended for uncomplicated acute bacterial rhinosinusitis, but is recommended when it fails empirical antibiotics. Similarly, in chronic rhinosinusitis, there is no evidence supporting the use of culture-directed antibiotics. And it's also important to keep in mind that microbiology doesn't give you information about the pathogenicity or the virulence of the microbe that is found. An important test in rhinology is the nasal nitric oxide. So nitric oxide is a gas that is present in the air exhaled, and it results from the production of endothelial and neuronal cells. The production can be constitutive, but can also be induced by inflammation. And NO is mainly produced at the level of upper respiratory tract. The measurement of NO is low invasive, low cost, and is objective. And our colleagues from pneumology use it quite often. They used exhaled NO, and it is known that ENO is elevated in eosinophilic asthma. And it's a useful tool in the management of asthma, and it's an objective measure of lower airway inflammation, even subclinical inflammation. In rhinology, we can use the nasal NO. It's mainly produced by the paranasal sinus. This technique is less developed than the ENO. And because there is frequent coexistent pathology between the upper and lower respiratory tract, it can be interesting to measure both exhaled and nasal NO. What is the best technique to measure the nasal nitric oxide? Actually, there are several techniques, but the best one seems to be aspiration flow on 700 milliliters per minute with breath holding for 10 seconds and with velum closure. And it's very important to have the closure of the velum to collect exclusively the NO from the sinus and nasal fossa. To close the velum, the patient has a resistor inside the mouth, and normal values are higher than 300 ppb. What is the usefulness of nasal NO? Is it useful for the management of sinonasal disease? Well, it may be in chronic rhinosinusitis with nasal polyps, and it's known that this patient have lower NO levels, and it's paradoxical regarding the high ENO levels. And these low levels are probably due to ostium obstruction. So the NO produced inside the sinus cavity cannot reach the nasal fossa. There is also a correlation between the nasal NO and the severity of the disease and polyps and CT score. So the lower the NO is, the greater is the severity. And this nasal NO can be improved, can be raised following medical and surgical treatment. In allergic rhinitis, the situation is less clear because allergic rhinitis patients with asthma have higher nasal NO, but there is a lot of variability of baseline nasal NO in these patients, and also there is modest change after treatment. So the value for diagnosis and management remains questionable. The main indication of nasal NO is probably in the assessment of primary ciliary dyskinesia, so PCD, because as you can see in this figure, nasal nitric oxide in this patient is consistently lowered compared to controls. And if the level is lower than 105 ppb, it has a sensitivity of 100% and a specificity of 88% to diagnose PCD. In children, it can be easier to perform nasal nitric oxide tests than saccharin tests. And interestingly, it gives similar diagnostic accuracy to electron microscopy or genetic testing for PCD when cystic fibrosis has been ruled out. Regarding cystic fibrosis here, you see that the levels are also decreased, but to a lesser extent compared to PCD. Unfortunately, this technique has some limitations. So first, it requires the collaboration of the patient, and usually it can be done in children older than 5 years old. There is an inter and intra-individual variability among healthy controls, and the level of nasal nitric oxide is influenced by environmental factors like smoking, exercise, nitrate-rich food. It's quite complex to use it in clinical settings, so it's mainly recommended in patients with PCD, maybe in patients with cystic fibrosis, and perhaps in the management of chronic rhinosinusitis with nasal polyps. Another test that is interesting is the measurement of the mucociliary clearance. So you know that normal mucociliary clearance is mandatory to have healthy sinonasal cavities. And if it becomes abnormal, this will lead to infection and chronic rhinosinusitis. It can be abnormal either due to congenital condition like primary ciliary dyskinesia, or it can become abnormal secondary to infection, chronic rhinosinusitis, or smoking. The most common test is the saccharin test. So a particle of saccharin is placed on the inferior turbinate, 1 centimeter from the anterior part of the turbinate, and the time taken to experience a sweet taste is measured. Normally, it's less than 15 minutes, but it should be less than 1 hour. Alternatively, this test can be performed using methylene blue, and the time to reach the hypopharynx is measured. Limitation is that it requires the collaboration of the patients. Patients must have patent nasal cavity without severe mucosal disease. When assessing patients with a suspicion of PCD, it's important to keep in mind that there is no ideal test that is widely available. We discussed about the nasal NO, about mucociliary clearance. Other tests can also be useful, like electronic microscopic evaluation of the cilia. You see here a structure of normal cilia with microtubule with Denyen arms here. And you see here pathologic situation with missing outer and inner Denyen arms and other pathologic situation here. Alternatively, evaluation of ciliary beat frequency and pattern can also be performed, either using digital high-speed video imaging or phase contrast microscopy imaging. So with these techniques, a region of interest is defined, and the beat frequency is measured using a Fourier transform, and the beating frequency is also modelized. Another technique is the ciliogenesis in vitro. This technique is used here in Belgium by Mark Jorissen. And so it's a cell culture and then assessment of structure of the cilia. As I told you just before, there is no test available in routine practice, unfortunately, for this patient. So we mainly rely on measuring nasal nitric oxide, and this test can really be considered as a screening test, and genetic testing is also important for diagnosis, but also for counseling. Similarly, in cystic fibrosis, genetic testing is also important, and sweat testing is also part of the classical evaluation of patients. Now I will discuss a few blood tests, so it's a non-exhaustive list. So I will discuss the usefulness for immunodeficiencies to evaluate the indication of biologicals or in evaluation of possible vasculitis. Some patients have particular clinical features, and you may think about immunodeficiencies in some patients. The most common is the IgA deficiency. Most patients are asymptomatic. It may lead to predisposition to chronic rhinosinusitis or allergy. Patients with hypogammaglobulinemia may develop idiopathic chronic rhinosinusitis associated with lung infection, pneumonia, bronchiectasis. And usually these patients fail standard treatment and they have a rapid recurrence after antibiotics. When you want to assess immunodeficiencies, you can measure IgA and IgG levels, and you can also perform a specific immunoglobulin response test after vaccine. Blood tests are also useful if you consider biological therapy. You see here the criteria from the HEPOS I previously showed you. And you see that the level of eosinophils and total IgE are among the criteria required to have biological treatment. Now, regarding vasculitis, in the area of the nose and paranasal sinus, there are two main vasculitis that we keep in mind. First is the GPA, so the Wegener syndrome, and the other one is the Shock-Strauss, so the EGPA. This disease have clinical feature with nasal obstruction, crusting, bleeding, rhinorrhea. In the GPA, patients have septal performation and sometimes saddle nose deformity. But diagnosis is sometimes difficult. And to help in diagnosis, ANCA serology can be useful for both disease. Importantly, biopsy can also be useful, but the results of biopsy is often poor because the material is not representative enough. Just a few words about the serology with ANCA. You see that based on ANCA, it's possible to have diagnosis of Wegener granulomatosis in 80 to 90%. So usually in Wegener, you have positive C ANCA that targets the PR3 antigen. This pattern may also be found in patients with Shock-Strauss syndrome. In Shock-Strauss syndrome, patients also have P ANCA targeted towards MPO. This profile is also found in patients with drug-induced vasculitis. So it's very important to keep it in mind. So when you see a patient with an important septal perforation, even if he has ANCA and MPO, it's important to ask whether he's taking cocaine because it can induce such serology. And just to finish, a last word about beta-2 transferrin. Beta-2 transferrin is a protein that is present almost exclusively in the CSF, and this technique is used to detect CSF leak. It has a high sensitivity and specificity. Among alternatives, you can use the beta-trace protein. This protein is also almost exclusively found in the CSF, and it has similar sensitivity and specificity. Some use glucose detection test strip. However, it has a lack of specificity and sensitivity, notably in patients with diabetes, hyperglycemia, or viral colds. As a conclusion, you see that there are several lab and blood tests that are available to help us. It's important to keep in mind that at initial presentation, diagnosis mainly relies on clinical examination and medical history, but don't hesitate to go further if the patient has not a classical presentation of the disease, if the disease is complicated or recurrent, or if you suspect severe disease, or eventually if you consider a specific treatment like biologics. I thank you for your attention.